session will about to start. For those who are joining, please ensure your devices and connection are well established for better experience.
The knowledge of anything, since all things have causes, is not acquired or complete unless it is known by its causes. Avicenna. Bismillahirrahmanirrahim.
Assalamualaikum warahmatullahi wabarakatuh.
Dear Your Excellencies, delegates, and ladies and gentlemen, good morning, good afternoon, and good evening wherever you are.
The Honorable Dean of Faculty of Medicine and Health Sciences, Universitas Muhammadiyah, Yogyakarta. Vice Dean for Academic Affairs, Student Affairs, and Al-Islam Muhammadiyahan, Faculty of Medicine and Health Sciences.
Vice Dean for Finance and Resources, Faculty of Medicine and Health Sciences, Universitas Muhammadiyah, Yogyakarta. Head of the Medical Professional Education Study Program, Faculty of Medicine and Health Sciences, Universitas Muhammadiyah, Yogyakarta.
Head of Pharmacy Study Program, Faculty of Medicine and Health Sciences, Universitas Muhammadiyah, Yogyakarta. Head of the Nursing Study Program, Faculty of Medicine and Health Sciences, Universitas Muhammadiyah, Yogyakarta.
Head of the Medical Study Program, Faculty of Medicine and Health Sciences, Universitas Muhammadiyah, Yogyakarta. President Director of Asri Medical Center.
Director of PKU Muhammadiyah Gamping Hospital. Director of Education, Research and Quality PKU Muhammadiyah Gamping Hospital.
The Chairperson of the 8th International Conference of Medical and Health Sciences 2024, Dr. Iman Permana, PhD. Our outstanding keynote speakers, Professor Dr. Nick Hazlina Nick Hussein, Dr. Mulyoto Pangestu, Professor Makoto Sawono, MD, PhD, Professor Dr. Srina Bawiyati Nurul Makiyah.
Our affiliate universities, Universitas Malaysia Perlis, Universitas Muhammadiyah Makassar, Universitas Muhammadiyah Klaten, and all distinguished guests for today's session.
Welcome to Indonesia's biggest medical conference,
the 8th International Conference of Medical and Health Sciences. With this year's theme, Innovate Health, Shaping the Future of Community Well-Being, from Program of Medical Studies, Universitas Muhammadiyah Yogyakarta in Yogyakarta, Indonesia.
Sugeng Rawo. My name is Nara.
And I'm Abi, and we will be your Master of Ceremony.
On behalf of the program's Executive Board, we extend our greatest appreciation to everyone for being able to participate in this unveiling event.
It is a remarkable moment. We will discover great collaboration among innovators who have dedicated their time and space for reaching sustainable development goals for the better of our future.
We welcome you to Indonesia, especially in this alluring, admirable city of Yogyakarta. So, as a Yogyakarta residents ourselves, as Javanese, allow us to extend our welcome greetings.
Yogyakarta is a special province within one of Indonesia's 38 provinces and is the foremost cultural center of Indonesia and home to majestic temples and palaces. Yogyakarta was known for its slogan, Jogja, the never-ending Asia, for its endless appeals, and today it is also renowned as Jogja Istimewa, meaning wonderful Jogja, a tagline that elaborates its spatial values.
International Conference of Medical and Health Sciences, an international conference organized by the Faculty of Medicine and Health Sciences, Universitas Muhammadiyah Yogyakarta. This event is expected to allow academics, scientists, regulators, practitioners, and any stakeholder around the world to exchange ideas or highlight innovation. In our 8th International Conference, we will uncover the latest and most advanced innovation in bioscience, biomedical, and physics toward achieving sustainable development goals.
For today's agenda, we will have greetings,
welcoming speeches,
plenary session of the 8th International Conference of Medical and Health Sciences 2024 with theme Innovate Health, Shaping the Future of Community Well-Being.
Then we will have First speaker, Professor Dr. Nick Haslina Nick Hussein from Universitas Malaysia with the title Women's Health and Aging.
The second speaker, Dr. Mulyato Pangestu from Monash University, Australia, with the title Medical and Social Aspect of Infertility in Community.
Then we will have the third speaker, Professor Makoto Sawano, MD, PhD, from Saitama Medical University, Japan, with the title Identifying Transmission of COVID-19 via Exhaled Breath Aerosol.
And our fourth speaker, Professor Dr. Sri Nabawiyati Nurul Makia from Universitas Muhammadiyah, Yogyakarta, with the title Dioscorea alata tubers for Food Security and Health.
Next, we will have Q&A session.
And last, closing.
Ladies and gentlemen, please welcoming speech from Dr. Iman Permana, PhD, as the chairperson of the 8th International Conference of Medical and Health Sciences 2024. To Dr. Iman Permana, PhD, the floor is all yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Alhamdulillahirabbil alamin. Sholli ala Muhammad wa ala Muhammad. Ladies and gentlemen, distinguished guests, Pak Dirwan as the Vice Dean of the Faculty of Medicine and Health Sciences, UMY, esteemed speakers, Prof. Makoto, Prof. Nurul Makia, Prof. Nick, and also I believe Dr. Mulyato is here with us today. Dr. Mulyato. Yeah, thank you. And also the delegates. One way to value good research, if it is not only the only way, is how implementable or applicable they are in everyday life of human being. The invention of steam engines in the mid-80s century had fastened further advancement of many more inventions that has been changing the life of humankind. Up until now, we cherish the existence of a non-feasible form of what we call electricity, for example, and we barely live without it. Yet, human being is still witnessing the ongoing thrive to the unthinkable form of creativity. Even up until now, we are still, I don't know, maybe struggling is not the proper word, in embracing artificial intelligence among our lives. And it will leave us with the big questions of how far can or do we want to go from now. Distinguished guests, esteemed speakers and delegates, on behalf of the organizing committee of HMIS, the 8th, it is my great honor and privilege to welcome you to an event that brings together brilliant minds, innovative ideas from around the world. We are delighted to host this prestigious gathering for the 8th times. And where experts from diverse fields converge to share knowledge, foster collaboration, and drive forward our collective mission of innovate health, shaping the future of community well-being. Yes, innovation has become the driving force behind progress, and its impact on health and community empowerment cannot be overstated. Distinguished guests and esteemed speakers and delegates, first and foremost, I would like to extend my deepest gratitude to our keynote speakers, Dr. Mulyato from Monash University, Professor Makoto from Saitama Medical University, Japan, Professor Nick Hazlina from USM Malaysia, and of course our local pride, Professor Nurul Makia, and of course Dr. Upi as our lovely moderator. Also our presenter and panelists who have traveled far and near to come to Jogja, to the lovely city of Jogja. And I believe Professor Makoto is enjoying to stay in Jogja because he said that Tokyo is far hotter than Jogja at the moment. And he told me that Tokyo has become a tropical city. Japan is tropical country now compared to Indonesia. Okay, we thank specially to all the keynote speaker and the delegates who come to Yogyakarta in person. I think the pandemic COVID-19 has taught us that virtual reality has becoming a current reality. We have been familiar with online meeting, and yet here you are with us here in this event. I think we have to give us a big applause for us now. Thank you very much. And I would like also to express our sincere appreciation to the Dean of Faculty of Medicine and Health Sciences, and also to the School of Medicine, FKIKWM, to support us in conducting this event. And also to our co-hosts from UNIMAP, University Malaysia Perlis, Universitas Muhammadiyah Makassar, and Universitas Muhammadiyah Klaten as our co-hosts. And also, not the least, to the members of organizing committee. Thank you for your tireless efforts and dedication. Your hard work behind the scene has ensured that every detail has been meticulously planned and executed. And also the LOs. Where's the LOs? Where are the LOs? Thank you very much for you for making the, what do you call it? The enjoyment of the event is more smoothly. Okay. And then again, thank you again for you all. I wish you all successful and enriching conferences. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Iman Permana, PhD, for the warm welcome. The next agenda, we will have welcoming speech from the Honorable Dean of Faculty of Medicine and Health Sciences, Universitas Muhammadiyah Yogyakarta, that will be represented by the Vice Dean for Academic Affairs, Student Affairs, and Al-Islam Kemuhammadiyahan, Dr. Dirwan Suryo Solarto, Specialist Forensic, Master of Science. Dr. Dirwan Suryo Solarto, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin wassalatu wassalamu ala asrofil anbiya'i wal mursalin Muhammadin wa ala alihi wa ashabihi ajma'in. Amma ba'du. Ladies and gentlemen, distinguished guests, esteemed colleagues and friends, especially to honorable to all speaker, Professor Dr. Nick Hazlina Nick Hussain from Universitas of Malaysia, Dr. Mulyo Pangestu from Monash University, and Professor Makoto Sawono, MD, PhD from Saitama University of Medicine, Japan, and Professor Dr. Sri Nabawiyah Nur Makiyah from Universitas Muhammadiyah Yogyakarta, and of course all invited guests. Good afternoon and a very warm welcome to the 8th International Conference of Medical and Health Science 2024. It's truly an honor to stand before you today as we gather for this prestigious event. united by shared commitment to advancing the field of medical and health sciences. This year's theme, Innovate Health, Shaping the Future of Community Well-being, capture of the essence of our mission and vision for the future. It underscores the critical importance of innovation, improving and health outcome, and emphasizes our collective responsibility to enhance the well-being of community worldwide. In the rapidly evolving world, the challenges we face in healthcare are become increasingly complex, from emerging disease to aging population, from mental health crisis to health disparity. Our task is not only to respond this issue, but to anticipate it and mitigate them through cutting-edge research, groundbreaking technology, and collaborative effort. Over the next few days, we will have the opportunity to delve into the diverse array of topics ranging from biomedical advancement and public health strategy to health policy and clinical practice. Our esteemed speaker and presenter will share their invaluable insight and latest research finding, fostering an environment of learning and inspiration. This conference is more than just a platform for sharing knowledge. It's a catalyst for forging new partnership, fostering collaboration, and igniting innovative ideas that will shape the future of healthcare. By coming together, we can accelerate the translation of scientific discovery into practical solutions that improve life and community. I would like to extend my deepest gratitude to our organizer, sponsor, and volunteer who tireless effort have made this event possible. Your dedication to advancement of medical and health sciences is truly commendable. As we embark on this journey of exploration of discovery, let us remain committed to principle of excellences, innovation, and cooperation. Let us challenge ourselves to think beyond conventional boundaries, to push the limit of what is possible, and to create a future where health and well-being are accessible to all. Thank you once again for your presence and participation. I am confident that this conference will be a resounding success, and I look forward to the meaningful discussion and collaboration that will emerge over the coming days. Let us now commence the 8th International Conference of Medical and Health Sciences 2024. Together we shape the future of community well-being. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Dirwan Suryo Solarto, SPF, MSc, for the speech.
Proceeding to the next session that we have been waiting for, the plenary session. And now we will introduce you to our moderator, Dr. Supriyat, SPOG, MCAS.
Her last study, she got her PhD degree in medical education from Faculty of Medicine, University of Münster, Germany. She is a research fellow in Health System Collaborative Group, Center for Global Health Research, Nuffield Department of Medicine, University of Oxford 2023. And also, she is a practitioner as obstetric gynecologist.
And she's also a lecturer here in medical program in Faculty of Medicine and Health Sciences, Universitas Muhammadiyah, Yogyakarta. She will take the lead from now on. Please welcome Dr. Supriyat Ningsih, SPOG, MCAS.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin wassalatu wassalamu ala asrofil anbiya'i wa mursalin wa ala alihi wa ashabihi ajmain amma ba'du. Honorable the Dean of the Medical Faculty and all the Vice Dean, Honorable also the Chairman of the International Conference, Dr. Iman, and of course for the all four speakers who will be as speakers in our afternoon session. Thank you very much for the introduction from the Master of Ceremony. And right now, I would like to lead the process of the plenary session, and that would be 4 plenary speakers. Number 1 is Professor Dr. Nick Haslina Nick Hussain. She comes from the University Science of Malaysia, and she will deliver the title or presentation with Women's Health and Aging. The second speakers will come from Monash University, Australia, Dr. Mulyoto Pangestu, from the medical and social aspect of her infertility in community. The third speaker will be Professor Makoto Sawono, MD PhD from Saitama Medical University, Japan, about identifying transmission of COVID-19 via exhaled breath aerosol. And the fourth speaker will be Professor Dr. Sri Nabawitati Nurul Makia. She comes from the University of Muhammadiyah, Yogyakarta, and she will deliver the title Diaspora Alata Tubers for Food Security and Health. And this session will be around 2 hours, 15 minutes, and each speaker will have 30 minutes for the presentation. And we would like also to invite all the participants into the session of the question and asking session at the 45 minutes after the 4 plenary speakers finish with their presentation. And this 8th International Conference of the Medical Health Science 2024 with the themes of Innovate Health, Shaping the Future of the Community Well-Being. So right now, we would like to invite the first speaker, Professor Dr. Nick. And before she gives her presentation, I would like to introduce her by reading her brief curriculum vitae. Oh, nobody will give the on the screen, yeah? Is there? Okay, thank you. Yeah, this is the brief curriculum vitae from Professor Nick Haslina. Professor Nick Haslina is a professor in obstetric and gynecology from the University Science of Malaysia, and she obtained her medical degree from University Kebangsaan Malaysia in 1990, and in 1997 she completed her postgraduate training. Her postgraduate training in Med OBGYN from USM and worked as a lecturer or obstetrician gynecology in the School of Medical Sciences, USM, since January 1998. And she also completed her 1-year fellowship training in reproductive endocrinology and infertility at Royal Women's Hospital and in Melbourne, in vitro fertilization, IVF in Australia, and she was also the head of Women's Health Development Unit, School of Medicine Sciences in USM from 2010 until the end of 2021. Her main research area are reproductive endocrinology, sexual health, women's health, and integrative medicine. She's very active with a writer with more than 80 publications at the national and international levels, and has authored and co-authored more than 40 books in Malaysia and also in UK. She's also very creative as a writer and published medical novels and also anthologies, and a regular newspaper columnist. She's a member of Human Research and Ethics Committee in USM. And right now, she's also as a editorial board member for BMC, Pregnancy and Child Health and Childbirth, and also honorary book reviewer for the University and National Publisher. And she's also one of the editorial committee for the clinical practice guideline for the management of menopause in Malaysia. Very complete of her achievement during her career, and right now we invite her to come to the stage, and the time is yours, Professor Nick.
Thank you, Dr. Supriyati Ningsih, for your kind introduction. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon. Salam sejahtera to all the to all ladies and gentlemen. First and foremost, I would like to thanks to Dr. Imam Pemana and also his organizing committee for inviting me to give a talk at this conference for the 8th International Conference of Medical and Health Sciences 2024. Without further delay, I will start my presentation with the themes of women's health and aging, actually. But the topic specific that I would like to share with you all, actually, is unveiling the empowered transition, thriving through menopause. Can you show the slide? Okay, sorry. Can you show again the first slide? Okay, thank you. Okay, this is the content of my presentation. First of all, we start with the aging population. What is the importance of the aging population and the impacts to our population now? And also, I will go through, be more specific to the menopause in general, and later would like to discuss a little bit on the treatment, and we'll focus further on the menopausal hormone therapy. And then the last one actually is a take-home message. Okay, for the aging population, I think that we need to concern about this problem now, because like in the 2015, the proportion of the world population over 60 years is about 12% in 2015, but it will be double to 22% in 2050. That means nowadays, that means the people are living longer. Can I have a look at the slide? Okay, and then okay, by the year of 2050, there will be estimated around 20% of the population in Indonesia will be aged 60 or older by the year of 2050. That means the number of people more than 60 years old will be increased rapidly in coming decades. This will cause major challenges, not just in Indonesia, however globally. So that's why it's very important for us now to understand and address the specific needs of aging women. That is a vital problem that we need to create a supportive environment that enhance their health and well-being throughout their later years. So sorry with the technical problem. Why I cannot control the slide? It's very fast. Okay. And this is the main thing that we need to concern, the lifestyle. I mean the impact of the aging population. There will be increase in the dependency ratio because there will be more older people and increase in the government spending, especially on the healthcare, because older people will suffer more medical illnesses, and also at the same time will be reduced in the productivity and the growth, because the aging affects individual in various ways across financial, social, physical, and also psychological. So one of the main focuses of women in the golden age is to stay as healthy as possible, because this will determine their independence and also their quality of life. Why this problem is important now? That we need to know about the women's life expectancy. Why now? This is because the life expectancy has been rising globally due to the advancement in the healthcare, nutrition, and also sanitation, and the rate varies between countries and region. And specifically, if you compare male and females, the female life expectancy is much more higher compared to a male. That means the women can live longer compared to a man. That means that if you can see from this slide, actually, like Japan, the life expectancy for a woman in Japan, they can live up to nearly 90 years. However, in United Kingdom, Australia, Singapore, and Switzerland, from this slide that we can see is around 84 to 86 years old. What about in our country, in Indonesia and Malaysia? We are the same, and look like the age of our women, they can live also longer, from the about 74 to nearly 79 years old. That means the women now, the age of the women now, if you compare previously, maybe about 50 years ago, most of our women maybe die at the age of less than 50 years old. So that we need to know also what are the typical age of natural menopause worldwide. Most of our women will be having menopause around the age of 48 to 52 years. If they live longer, up to about 75 average, that means 1/3 of their life actually is during the menopausal age. So that means menopause is becoming a major public health issue that we need to concern. Oh, very fast. So sorry, not so friendly. Very fast, this one. Only press once, but oh, okay. Oh, you want? Oh, Sabrina, maybe you can control. Go back to the. Next. Previous. It's not working. Previous slide. Cannot. Actually, it's not. It's difficult to control. It's not friendly. Okay. Thank you. Okay, next. Okay, next. Okay, just wait here. Okay, thank you so much. So sorry for the technical problem. Okay, because before we go further, actually it's good to know that the term of menopause. What is menopause really? Menopause really comes from the Greek word men, meaning as months. Pause or pauses means as cessation or stopping. That means thus literally the menopause is defined as a stopping of a woman's monthly menstrual cycle, reflecting the end of menstruation and reproductive phase in a woman's life. Next. And then, according to WHO, in 1980, define that menopause as a cessation of menses for at least 12 months duration. It's a natural phase of life that transitions as part of a biological aging, a distressing stage that impairs quality of life among women, and also reflect complete or near complete stage of hypoestrogenism. And this can increase risk of cardiovascular disease, osteoporosis, and also sexual dysfunction. Next. Okay. And also, it's nice to know also, what do you mean by early and premature menopause? Early menopause and premature menopause also important to know because it's referred to the cessation of menstruation before the typical age. The typical age is about 48 to 52. However, if the women experience menopause less than 40 years old, it's defined as premature menopause. And if they experience less than 45 years old, considered as premature menopause. And the causes that are listed here, like the chemotherapy, a combination of both also, either it's a chemoradiation or bilateral removal of the ovaries, chromosomal abnormalities, autoimmune diseases, smoking, infection, such as due to mumps, simple disease, but also can lead to premature menopause. However, in about 50% of the cases that having menopause either early or premature, the cause still remain unknown. And this one we call that as a idiopathic premature menopause. So this slide shows actually the stage of the menopause that we need to know also. Menopause is a natural biological process that occurs in stages. The stages, the important stages that I already mentioned just now, the menopause, that means the last date of the menses is a final menstruation, is the menopause. But the period before menopause is commonly stated as a menopausal transition or climacteric stage. And the period after menopause is post-menopause, and the period in between, either is a before or after, we call as a perimenopause. Okay, next, please. Okay, what are the symptoms of menopause? That means the menopause can cause all sorts of symptoms. That means can start from the head to the toe of a woman. But that from this slide that we can see that we can divide the symptoms into the early, intermediate, and late stages. Like the early one, usually the patient, the women, will experience hot flushes or also vasomotor symptom. Other than that, night sweat, insomnia, menstrual irregularity, and also of psychological symptoms, mood swing, irritability, depression, poor memory, especially the short-term memory, headache, and also palpitation. And then in the intermediate stage, the most of our women experience vaginal atrophy, dyspareunia, loss of libido, skin atrophy, and all sort of urinary problem, like incontinence, frequency, dysuria. And later in the late stage, they will have a complication of like a long-term problem, osteoporosis, atherosclerosis, coronary heart disease, cardiovascular disease, and also Alzheimer disease. Next, thank you. Okay, from this slide that we can see that menopause and the GSM. GSM stands for the genital symptoms, genital symptom of menopause. GSM. That means the menopause can affect the genitourinary tissue that can lead to discomfort, pain during intercourse, stress incontinence, and also sexual dysfunction. Okay, next. And with the problem of the hypoestrogenism that can affect the production of the bone mineral density, that means the women are prone to present with osteopenia and also osteoporosis. And next. And also, this is the main problem also that can affect the quality of life. That means the symptom impact quality of life is varying around the world. This is due to the range of different problems, like different factors, including the cultural, social, economics, and so healthcare differences. Like from this slide that you can see here, like in Africa, most of the African women during menopause, they might experience sleeping disorders as a main problem, depressive disorders, hot flushes, and also joint problem, myalgia, and also arthralgia. However, in women like in Asia, in our country, experience more than 50% we experience sexual dysfunction, depressive disorders, hot flushes, myalgia, and also arthralgia. And next. please. And also, we need to know also the menopause and the cardiovascular disease. This is also the main issue that we need to know that might happen, especially to the menopausal women. This increase the risk of cardiovascular disease because of the increase in the blood pressure, reduce in the glucose tolerance, and also because of the endothelial dysfunction. Next, please. Menopause and the cardiovascular disease. This is a main topic that was highlighted during the Menopause Day last year by the International Menopause Society, that they are very concerned because cardiovascular disease actually remains the number one cause of death among our women actually. It's not the cancer, it's a cardiovascular problem. And the most common non-communicable disease globally, that they stated that 35% of death in women each year is 13 times due to cardiovascular compared to the rate of breast cancer and other types of cancers. Because women actually, unfortunately, they present with the atypical presentation, not the typical like for the men, a chest pain. But usually the women, they present with the very unrelated problem that this then can cause a delay in diagnosis in the emergency department. Unable to know that they have a either it's an infarction or coronary heart disease. Next. These are the risk factors. There are 4 potential risk factors that can affect the cardiovascular disease among our women actually. Number 1 is the cardiometabolic health changes during menopause and the symptom of menopause, especially the vasomotor symptoms. And the thing that we need to know also about the reproductive lifespan and also about the treatment, menopausal hormone therapy. The next, please. Okay, for the cardiometabolic disease risk factor, the number 1 risk factor, there will be increased prevalence of the metabolic syndrome that occurs during the menopause transition, usually presented with a subclinical atherosclerosis. And also because during this period, women they prone to get weight gain and redistribution of the abdominal obesity, especially the visceral adiposity, will be also increased. And also because of this problem, they might present the increased insulin resistance and also increase in the lipid profile, especially the LDL and the triglyceride. That also can affect in the cardiometabolic profile. Next, please. That we did a study previously in 2010 among our postmenopausal women in our center in Hospital Universitas Malaysia, among 400 women that menopause either surgically or medically menopause, naturally menopause, that we recruited, we screened for the metabolic syndrome. And from our study that we published already in 2012, we found that prevalence of metabolic syndrome in our setup is almost 40%. That's why the thing that I would like to mention here actually is good for us to screen all the menopausal women, especially for the metabolic syndrome. Because like from our previous study, 40%, we managed to get 40% prevalence of the metabolic syndrome among our postmenopausal women in our hospital. Next, please. Okay. And number 2 cardiovascular risk factor is vasomotor symptom. Because like cardiovascular risk actually associated with vasomotor symptom, sleep disturbances, and also depression. And if a woman having an early onset of vasomotor symptom, the symptom either is a persisting or declining, this one also can increase the risk of carotid intimal media thickness. That means the risk to get cardiovascular disease. So that's why in the International Menopause Society stated that vasomotor symptom may be an emerging as a novel, as a biomarker, a specific marker for female-specific cardiovascular disease risk factor. Like for men, erectile dysfunction is also cardiovascular disease risk for a man when they are having impotence or erectile dysfunction. But for a woman, it's a vasomotor symptom. That they got a cardiovascular disease risk factor. That means early occurring vasomotor symptoms are among the strongest predictors of subclinical cardiovascular disease. Okay, next please. And also with the vasomotor symptom, women with frequent hot flushes have been shown to have a twofold increase in developing coronary heart disease over the next 14 years, irrespective of their age, menopause status, lifestyle, and other chronic diseases risk factor when compared to a woman with no symptoms. This due to the poor endothelial function, more active calcification, and greater intimal thickness. Next, please. And number 3 is the reproductive lifespan. It's also nice to know about this problem. Reproductive lifespan actually is defined as the extent for a woman that when they have the first time menarche until they menopause, with an approximate duration for a normal woman about 40 years. I'll give example. If they menarche at the age of 10 or 12, and when they got menopause at the age of about 50, 52, that means almost 40 years. That's normal, still okay. However, in a woman experience menopause early, less than the age of 40, with a reproductive lifespan less than 30 years duration, there will be increased risk of cardiovascular disease. And because of shortened reproductive lifespan has been associated with increased risk of ischemic heart disease, congestive heart failure, and also diabetes mellitus. Next, please. Okay, number 4 is the menopausal hormone therapy. If you want to start the hormone, actually to start menopausal hormone therapy, previously known as HRT, but now for the past 2-3 years, they changed the HRT to the MHT. That's why they call it as a menopausal hormone therapy. You want to start early within the 10 years of onset of menopause or before the age of 60. If after than that, it's better not to give because the risk to get heart attack, stroke, thrombosis. That means if you start later, there will be more risk, especially for the cardiovascular disease. You want to start early, soon, maybe just before menopause or after menopause. Okay, next please. Okay, like for the treatment for the menopausal women, that we can divide it into 3 main big categories: lifestyle changes, non-hormonal therapy, and also menopausal hormone therapy. Next please. Okay, for the lifestyle changes, this is a general advice: healthy weight, balanced diet, nutrition, cutting down excessive coffee, spicy food, quit smoking, regular exercise, improve daily activity, adequate quality sleep, manage the stress, try to avoid a toxic environment, maybe toxic friends, better to work in a conducive environment, do something that you would like to do. Like for me, I like to write books, novel, that is good for the stress also, and also a support group training program. Support group training program is a very important program also. And also for this group of women, they need to have a regular checkup, especially for the metabolic problem and also cardiovascular disease. Okay, next please. Like for the support group training program, they have a significant effect on the accepting physical, psychological, social changes induced by menopause. Because when they have a good a sharing program, they can share together, they can ventilate the problem, and this one can be helpful and can also reduce the stress among the women, among the menopausal women. And also the most important thing, actually the participation of other family members, especially the husband. That's why you want to treat a menopausal woman, treat the spouse also. Need to treat the spouse also. That's why we managed to do a study actually and publish, like from our my PhD student, Dr. Intan Idiana. She did a study that they educate the spouse to help the wife during the menopausal transition. Okay, next please. Like this one, the slide that about medication. That is just nice to know about the MHT. The most important, either that we need to concern patient got the uterus, still have a uterus, or already undergone the hysterectomy, removal of the uterus. You still have the uterus, you can see the slide here that menopause less than 1 year or more than 2 years. It's just recently less than 1 year. That means we need to give a cyclical HRT or MHT, cyclical MHT. That means patient still having a menses bleeding at the end of the cycle. However, in the patient that already established menopause more than 1 to 2 years, we can start the continuous combined MHT. That means no non-bleeding, non-bleeding. However, in the women that already have a removal of the uterus, we can give a estrogen therapy only. And for the hormonal, these are the one that I've listed here, is available in Malaysia, like the Remifemin, Fem-E, Serm, Evista. However, in our hospital also sometimes we offer to a women to be on a regular natural supplement like the honey or the bee product. And also we conducted a big study using the honey among the postmenopausal women. Okay, next please. Okay, for the alternative therapy, usually most of our women we consider alternative therapy if they are very fierce of the try not to use MHT. That means they will use the alternative therapy, or if they have a history of breast cancer or other medical disorders that I listed here. Okay, next please. But hormone therapy should not be recommended without a clear indication. That means we cannot start MHT to everybody only when they got the indication, especially the indication of the vasomotor symptoms. Okay, next please. And also, it's important to know that perimenopause, that means the period just before and after menopause, is a period of vulnerability as well as a window of opportunity. Next, please. Treatment is important. Like for this one, you want to start a treatment for a patient, for a woman, menopausal women, you want to start early. You need to initiate the treatment as soon after menopause or just before menopause. That means the women will experience more benefit that we regard to the relief of the vasomotor symptom, mood symptom, treats the genitourinary syndrome of menopause, reduce the connective tissue loss, and in general improve the quality of life. And also as a prevention long-term strategy to reduce risk of osteoporotic fracture, reduce risk of coronary heart disease, cognitive problem, and reduce all-cause mortality. Next slide, please. Okay. And timing is everything. Timing is very important. You want to treat the women, menopausal women, start early. If you want to see later, no need to give already. There will be more harm if they menopause more than 10 years. That means if you start early, there will be decreased risk of coronary heart disease by 50% and decrease all-cause mortality by 30%. That means the sooner estrogen is replaced, the sooner that means the symptom resolve, and they will protect their problem, especially the long-term problem with regard to the cardiovascular problem and also the bone problem. Next, please. Okay. And also for the MHT, there is presently no time limit, not just to take for 1 year or 2 years. No specific time limit for the duration. However, every woman on MHT should have that means you need to balance regarding the risk and the benefit. That means we need to assess the patient on a regular basis. And patient care should always be individualized. Maybe different patient need different medication and different type of MHT, and the duration also may be different. Next, please. These are the contraindications that I've listed here. Okay, next, please. This is a global consensus on the usage of the menopausal hormone therapy that was stated by the International Menopause Society, the Endocrine Society, the North America Menopause Society, and the Reproductive Medicine, American Reproductive Medicine, International Osteoporosis Foundation, the European Menopause Association Society, and also the Asia Pacific Menopause Federation. This is a consensus that benefits are more likely to outweigh the risk if you initiate the treatment for asymptomatic women before the age of 60 or within 10 years of menopause. And duration of treatment should be consistent with the treatment goals, and you need to balance the benefit and the risk, and need to individualize the treatment to the patient. MHT should be part of an overall strategy aimed to improve their midlife health, especially on the quality of life. Next, please. So that means it's time that we should offer the best and the proven treatment to the menopausal women. Next, please. Okay, this one actually I'm one of the panel for the menopause guideline that we launched in Malaysia about 2 years ago. This is a guideline that I passed already, the one of the hard copy to Bu Upi last night. And then I have also the electronic guideline that I can pass to anybody that if you want, that we launched last year. This is our guideline about the clinical practice guideline management of menopause in Malaysia. Next, please. Okay, and with regard to our menopause guideline, like Hemachandra et al. Managed to do a systematic review and critical appraisal on the menopause guideline that are available worldwide actually. And one of our guideline also in the review, and according to this group, they managed to publish a journal on this appraisal and the systematic review that was published about few months ago, that they criticized on the all the guidelines that are available worldwide, and their comment, the conclusion that they made actually amongst all the menopause guidelines in the world, they stated that menopause full guideline, clinical guideline methods, evidence and recommendation by the NICE and ICE in 2015, and the CPG management of menopause that was published by our group in 2020 are the best guideline, are of highest quality. Okay, next please. Okay, this is the last slide. Okay, as a take-home message, that impact of aging population, that we need to know the importance of that, the impact, and the age of menopause also fixed 48, 52. However, our women may live longer now, so that menopause becoming a major public health problem. And also we need to know about the cardiovascular disease remain the number one cause of death, not the cancer, and the atypical symptoms of the chest problem, coronary heart disease, that might delay in diagnosis of the coronary heart disease among our women. And also, one more thing is about vasomotor symptom may be emerging as a novel female-specific cardiovascular disease risk factor. And for women experience menopause less than age 40, they are at higher risk to get a cardiovascular disease risk. Okay, and also perimenopause is a period of vulnerability. You want to start the medication, start early. Catch them during this period. So MHT is best initiated in a women who are within 10 years of menopause or age less than 60 years. And also MHT got many positive balance, risk benefit balance positive that can alleviate the vasomotor symptom, mood symptoms, treat the genitourinary syndrome of menopause, and in general improve the quality of life. The last slide, next slide.
Your
Okay.
time,
Okay.
1 minute slide.
Just this one, the last slide only, Bu Upi. Sorry. Okay. I would like to inform you, I'm the co-chair for this conference that will be held in Kuala Lumpur next year. The Asia Pacific Menopause Federation 10 Scientific Meeting that will be held on the 25th to 27th July 2025. I would like to welcome you all to this conference. So that maybe you can Google, you can get go to the website and try mark the date, and also can register. You are all welcome to join the conference for the Asia Pacific Menopause Conference that will be held in Kuala Lumpur only. It's very near. You can take a 2.5 hours flight only to go to Kuala Lumpur from Jogja.
And
Okay,
direct
that's
flight.
all. With that,
And
we end
direct.
my session. But I'm so sorry with the technical problem. I'm not so familiar with the just now the technical thing that was prepared here. I'm so sorry for that. With that, I end my presentation. Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Give the applause to Professor Nick. Thank you very much for a very interesting presentation. If you have some question to her, so please hold until finish all the plenary speakers. I would like to invite Professor Dr. Mulyoto Pangestu, and I would like to reach out him on the screen because he will be online from Australia. Hello, Assalamualaikum, Dr. Mulyoto. Assalamualaikum. Unmute. Dr. Mulyoto, you are still mute. Maybe the committee, can you help? Committee, please, can you help to open his speaker? Microphone, sorry. Hello? Dr. Mulyoto? He's still mute. Oh, okay. Halo Dr. Mulyoto, Assalamualaikum warahmatullahi wabarakatuh. Okay. Dr. Mulyoto Pangestu from Monash University, Australia, he would like to give his presentation with the title Medical and Social Aspect of Infertility in Community. Before his presentation, I would like to introduce his curriculum vitae. In summary, he's graduated as a bachelor's in animal husbandry or animal science, agriculture, and forestry. And he has very strong knowledge in embryo cryopreservation, reproductive technology, and excellent in organizing laboratory and skill training in clinical embryology. Years of experiences in teaching 30 students in Faculty of Animal Husbandry and Faculty of Medicine. He's also very actively writing, lecturing, seminar, and presentation around the world. He's also able to work accurately and efficiently under very tight timelines. And he's also able to develop and strengthen internal and external relationship through well-developed written and verbal communication skills. And he also has community experiences. Right now, since 2009 until present, he is the director of Al Jannah Funeral Services, and also from 2006 until 2007, he is the former acting president of Indonesian Muslim Community of Victoria, Australia. So very excellent of his experiences and achievement. And right now, I would like to ask Dr. Mulyoto, the time is yours.
Thanks for the moderator. First, I would like to thanks for the invitation. I'm very honored to be able to give my presentation in this conference. And yeah, my presentation might be a bit short, but I hope all of you can enjoy my presentation. So I would like to mention first about the infertility in community. We look at from the medical and social aspect. Before I start, I would like to give my disclaimer. This presentation is only for scientific and teaching purpose only. If there is an audience who experience similar situation, it's just coincidence. So we go back to the definition. Most people will say the definition of the family. Family is the basic unit in the society, usually consisting two parents and their children, which is quite common. It's very common in community in Asia, especially Southeast Asia. They all start from the family. Anywhere we talk about developing the nation, strengthening the nation, I will start from the family. So since I mentioned that the family is comprised of the parents and the children, now the question is, what's happened if there is no child in the family? There's not one, or two, or three. As we were this situation affect about 15% of the reproductive age couple. We were that this become what they call it, the rumors, can be a hope, can be a dreams of a family, or even in some cases in Indonesia, there are some story or fiction about infertility in the family. There is quite popular story in Indonesia. One was the Tukang Bubur Naik Haji, which is quite long sinetron running for many years ago. This sinetron mainly about the Mat Solar and his family, but then behind that, we know that Mat Solar and his wife Uci Ping Slamet don't have children, and also the parents of Rumana. When he got married to the second wife, he tried to get his own child. So, being infertile, Mat Solar has been bullied by the community, especially by Rumana's parents. But he kept going on that one. However, every night when they were home, there's always an issue between them. The most recent one was the movie they call it Pasutri Gaje. This by Reza Hardian and BCL, this Indonesian famous movie stars. This movie telling about how when someone get married and they don't have children, they haven't got children yet. So every night the parents of BCL was asking when you start get pregnant and everything. So this is the fiction of someone's getting infertile. But on the other hand, I think many Indonesians aware about Inul Daratista. Inul was one of, we plan to put Inul as an ambassador for Indonesian IVF. That was planned in 2016, but unfortunately it has not happened. Inul is very open artist. She's been talking everywhere before 2005 that she and her husband experienced infertility. So she's been everywhere. She's been overseas. She's been tried in Indonesia and every clinics until, if I can recall, around November 2008, Inul declared that she got pregnant through IVF, and since then, the public in Indonesia start aware. There's an IVF service in Indonesia. Before 2007, the number of cycles in Indonesia, the whole Indonesia, out of I think it's about 10 or 9 clinics, they have less than 300 cycles a year. Once Inul declares she got pregnant, then the cycles double. So in June 2009, the number of cycles in the year similar to the number of cycles the whole year in 2009. Now Inul's happy, live with his family, with his son. But if you look at the reality, what is infertility? As I mentioned earlier, it's a fact one of 6 couples. That's about 15% of reproductive couples. What's the impact of infertility in the family itself? One, it's a common when the couple try to conceive to have their own children, the wife try to conceive their pregnancy, then they'll go to a doctor. They're seeking medical advice. Medical advice, I call it, is not cheap because they have to buy by themselves for the consultation, for the medication. So it will end up the economic burden on the family because the cost of the treatment also not cheap. For instance, if they can look at do laparoscopy on the wife, on the women, it'll cost around 20-25 million Indonesian rupiah. It's equal about $2,500 US. Oh, sorry, about 1,500 US dollar. If they could look at the husband, it's pretty cheap. It's probably around less than 1 million. But the problem is, many men, they don't want to be checked on their sperm quality. So this become an on and on economic burden. On the other hand, they also have a social pressure. As I mentioned earlier in the story of keluarga Gaje, Pasutri Gaje, they got the pressure from the family itself. The parent was asking, hey, you got married when you give me a grandchild. It's quite common in Indonesia. That request is very common. The brother, sister, siblings start asking, hey, when you gonna give my niece or my nephew? Friend in the office, friend, neighbor start talking, hey, when you start get pregnant. So it's common in Indonesia. About 3 months, 6 months after someone get married, then the friend asking, hey, are you still getting pregnant or no? Then that question looks simple, easy to say, but the consequences of that question is very hard. If that couple think that they're gonna delay their childbearing or pregnancy or anything, they may easy to answer. But if the couple's been trying hard to get pregnant, I mean, the wife get pregnant, then it is a very difficult question to answer. So when we're talking infertility in the community, the pressure not come up from the couple itself, but it come from the family. The family is sometimes getting worse. The parents of the husband and the parents of the wife, they blame each other. Ah, your daughter's infertile, couldn't give my son a kid. So the parents of the wife will say, hey, no, your son is infertile because he cannot make my daughter pregnant. Then it's become a big issue. If we look at in the infotainment, in TV or anything, we've been seeing that many couples, celebrities, get divorced because they couldn't get their own children. So this is not something that we can just ignore it. There is something serious behind that. If you look at bit deeper, WHO already defined infertility as a disease of the male or female reproductive system defined by the failures to achieve a pregnancy after 12 months or more of regular unprotected sexual intercourse. So it is clear that WHO say infertility is a disease. It is not a condition. It is not something that you can do it voluntarily, but it is a disease. So if we look at infertility, we can treat them as not different to you having COVID, you having heart disease, you having cancer. There's a disease. The only problem is the infertile couple or anyone who infertile, they looks healthy, meaning they don't have any pain, probably if they have endometriosis, but the male except they got infection, but they look healthy, they look strong, they look normal like other people. They don't see any morbidity, they don't show any pain, but I mean physical pain, but deep inside their heart, their mind, or their emotion, there is an issue. So being defined as a disease, infertility is supposed to be covered by universal health coverage. But unfortunately, only few countries cover infertility, even though they cover, but they not cover everything. So as a precaution, don't just blame the female. It's quite common in some countries. Some couple couldn't get pregnant, they'll go to an obstetrician. Why? They need to check the women first. That's not always right. The best way, check the male first. Check the male and make sure the male is good, the sperm quality is good, because checking male fertility is the most easiest one. Just produce the semen, we look at it, and then spot on, we can tell, do you have enough concentration? Do you have enough motility? Do you have enough normal morphology sperm? Then from then we can start, okay, everything's good, everything's normal, let's go look at the female. Then we can ask the female, how's your menstrual, how's everything? Then this history can come up, put into together, and then we can say, yeah, we may have to do something because we can make a proper diagnosis, which is sometimes we call it unexplained infertility. But if it's clear that we have to do hydrosalpingography, then look at there's a blockage in the fallopian tube, or there's a heavy bleeding from menstrual from the endometriosis, or any polyps in the endometrium, then that's when we start moving to the female side. However, if there is a problem on the male, so it's easier to get the male side, you go astenoteratospermy, then yep, we can look at what's happened. Some causes of infertility can be prevented, such as some infertility occurs due to lifestyle. For instance, smoking, working overnight, working in different time zone in a short time, or exposure to extreme temperature, like especially exposure to heat, previous infection, or stress during working. Some people might thought that, I'm living in a good shape, I do exercise every day, I'm not smoking, I sleep at 8 o'clock or 10 o'clock at night, but the pressure in the workplace, it might lead to infertility. So that's when we say it can be prevented. It's like taking a break for 1 month or 2 weeks or 1 month, have a holiday. It might reduce the stress and may bring the infertility back, but it's really depend on the problem. The treatment, as I mentioned, the top one may have to involve in vitro fertilization or other types of medically assisted reproduction. However, some infertility, if we have to go to assisted reproductive technology, then this ERT is not curing the infertility. It's just helping to achieve pregnancy. There's some infertility curable or non-curable. The curable one is simple, the one that coming from the lifestyle, or if someone just needs surgery, or need to clean up like the polyp in the endometrium, then you can easily remove the polyps, or someone just need hormonal manipulation to bring everything back, then yeah, that's okay with that. The non-curable one, it might need an assisted reproductive technology, such as if you got infection on both oviduct or fallopian tube, then of course the egg never come down into the the egg never met the sperm along the way, and the embryo never been formed. So that's when you need an IVF, or the males having problem with astenospermy due to infection or some blockage, or the fast difference not normal, then of course we need to get the sperm straight from the testicle, and we have to go through IVF. So how can we see infertility in the world? I mean, as I mentioned, the infertility is not just dominant. Infertility is not just dominant in Asia or Africa or Middle East, but it's come up in the world. So many years ago, like back in the day, when everything is still conservative, most people tend to keep quiet in infertility. They don't want to discuss about infertility in front of the community. They prefer to stay quiet, and they don't want to be known they're infertile. In Indonesia, there are some issue like I'm gonna call it treatment, some way to get their wife pregnant, like swap the key for the husband and everything, is an old Japanese culture. But no longer doing that one. But as I look at in the Western society, which is more liberal, more open, so the way they look at infertility is they look at how they talk. No, it's big changing in the Western country. So they start talking each other like, hey, it's got infertility. They start going public. They're asking people. They're asking doctor. They want to open. The Asian culture, some Asian cultures start open, such as Japan, Hong Kong, Taiwan, Korea. They start open when they're talking about infertility, but further down, like Vietnam, Thailand, Malaysia, Indonesia, they're still not that open. The same as in India and Middle East country. In the African region, the big progress in sub-Saharan Africa, like northern Africa, but in the southern and mid Africa, in the Central Africa, they're still having issue, such as the very limited resources and everything. So there are infertility problem in that area, but the resources is not as good as like in Europe or even in Asia. When we talk infertility, I would like to give an example. The easiest, my favorite country to give an example is India. When we're talking about India, India is a country with billions of people in there. And India, amazingly, they have the number of IVF clinic in India is higher than the total number of IVF clinic in Europe, in America. So, about 5 years ago, this about 500 clinics in India, and now about more than 500. So, if we're talking that one, then people start thinking why the country with very dense and highly populated still need an IVF. Because having a children in the family, I'm not saying it's a must, but then it's become something compulsory. Someone get married 3 months, 6 months, no sign of pregnancy. The risk is the husband gonna be left the wife, divorce the wife, looking for another wife. It looks cruel, but that's when you look at the women position within infertility in the community. I'm not saying they're not paying attention, but then that's when we need to speak up that, hey, it's not about the man, not about the female problem. This about both male and female problem. So we cannot just say, hey, the couple couldn't get children, and then, yep, send the woman to the doctor, check from the head to the bottom, everywhere, everything's normal. When we call the husband to come, hey, can you come have a sperm check? Oh, sorry, I'm busy, I'm this. So many excuses. So we need to look at that both male and female equally contribute to infertility, not just one. Since the women get blamed, so women also get stress, they experience violence, divorce, social stigma, depression, anxiety, and low self-esteem. I mean, we need to build understanding in the community. Hey, this is not women issue. This is both men and women. I'll just put in like illustration like the stars in the Sex in the City. So they like the Charlotte York has been doing everything to get her pregnant. So husband and wife has been making effort. They understand, but not every couple understand about the situation. I'm not talking about the cause, but I'm talking about the understanding and responsibility. So once the males know that they are infertile, it's a different. The male can be more stressed than the women when they found out they're infertile. They don't want to be known. Then the male feels this no longer a male, no longer a man. They feel they're useless. Once they into the situation, they also need support because they're having trauma, because they're being infertile. Then we cannot just let them go on their own. As I mentioned earlier, that some infertility can be recovered, can be cured, but some of it is permanent. That's it. Nothing can be done. Or even worse, if they can be cured, but if we fertilize the egg with your sperm, then potentially the embryo or the child will inherit the infertility from the father, which is bad. I mean, we aware that we have Klinefelter syndrome, and then we fertilize the egg, and then we know that the offspring, the child, will potentially having the same problem. So it is very inconvenient, very, very stressful for men, not just men, for the couple, if they found out that this is their situation. So if you look at that one, let's look at the lifestyle. in male infertility. We know that all external factors lead to oxidative stress. Someone never do exercise, it might cause oxidative stress in increasing fat in the liquid in the body. Drinking coffee, yeah, for some extent is good. High fat diet. Stress, too much eat red meat, not enough fruit and veggie, or exposure to high temperature. It will damage the reproductive system. They make sperm DNA damage, impair the sperm quality, and of course, it's end up with male infertility. However, those conditions can be recovered. It's not permanent. So as long as this person still young age, say under 25, 30, then yeah, still it can be recovered. But once they go beyond 40, then of course, we don't know what's happened. When we look at this condition, like either on male and female, like lifestyle, occupation, genetic factor, medical physical condition, then that's when we look at the effect like psychological, they can get angry, depression, anxiety, psychosocial, less esteem, poor quality of life and social isolation, psychoeconomic because they have to spend money for medication. So anyone experience this situation, of course, if we knew someone experienced this situation, they need to be referred not just a doctor. They need to be referred to a counselor, which is quite uncommon in Indonesia for a patient to see a counselor. I have experienced sending my patient to a counselor. And then what's the response? I'm just infertile. I'm not insane. Then where you send me to a psychologist? And then say, no, you need someone to help you understanding your situation and then reduce the stress from you. Because reducing the stress, it might help the couple to achieve the pregnancy. As I mentioned earlier, stress not just because of working, but stress of society, stress from any condition that's been there. Then when they don't have stress anymore, they all settle, then somehow they can get pregnant naturally. I got experience another patient. They've been trying IVF for a few times. It's nothing working. Until states when those couple, I call it like give up. I call it give up. And then suddenly, bang, they got pregnant. So they went back to the clinic and they sued the clinic saying, hey, the clinic been playing with me. I'm good, I'm normal. You give me medication, make me swing mood, stress and everything. And now, when I stop the treatment, I'm back to normal. I get pregnant. That's not the case. The case was when the couple went to the IVF clinic having the treatment, so the couple want something, really want something. When someone wants something, I call it stress. It's another type of stress. Like as a children, having a cold or flu, and then let the children having fun or play with the other healthy children, then all kids having an ice cream. Of course, the one that flew, the parents won't give her ice cream. Of course, this kid crying. I want ice cream like my friend. Don't care. I got cold or no, I want ice cream. So this the situations might be experienced with that couple because when they went to infertility clinic, they really want, and then suddenly when they stop, yeah, all back to normal, the hormones back to normal, and then they just get pregnant. So
Dr. Mulyoto,
Even
your
in
time
fertility.
remains 2 minutes.
Yep. We need to change our lifestyle. Maybe we need to change the job if necessary. It's quite clear. And if we need to treat infertility, then whether we change the lifestyle or taking medication, some other have to go through an IVF, some other they can't go through IVF at all. So the choice either way, they do another step of treatment such as donor, gametes donor, or surrogate or embryo donation. So I would like to emphasize that assisted reproductive technology is not a treatment, but it helps. And if the couple succeed pregnancy with ART, they might need the second ART to achieve the second or the consequent subsequent pregnancy. And as I mentioned earlier, some people potentially inherited parents' infertility. So this was happened with Inul. Again, she's been bullied by the family, by the community, and until she wants to adopt a child, but luckily she got pregnant. And what they said about infertility in the world, there's many papers, many books talking about infertility in the community, from Asia, Africa, Europe, and America. They all discuss about that. And what will we do? So we need to build on community awareness that infertility can be treated or no, men or women. Women also get blamed, cultural view, counseling, government support, access to treatment, and educating community. So we can reduce the stress or burden on the infertile couple. Let's look at in Indonesia. Up until December 2022, there was 49 registered IVF clinic, 4 in Sumatra, Java 39, Bali 4, Borneo 1, Sulawesi 1. But the number of patient or cycles is only 8,033, which is far below the capacity, which far below the potential number of patients, which is Indonesia, based on my calculation, at least every year we have 50,000 potential patients that need and can afford to buy IVF. So I'm glad that I heard that Muhammadiyah Hospital in Gamping will start an IVF clinic soon, and I hope they will give a support to the community surrounding the area. And to close, I would like to thanks to the organizing committee of ICMHS at Universitas Muhammadiyah, my head of Department of Obstetrics and Gynecology at Monash University, and director and colleagues at the Education Program in Reproduction and Development, Monash University. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Applause to Dr. Mulyoto. Thank you very much for very interesting presentation and also your support to our center in PKU Muhammadiyah Gamping Hospital. Right now, we would like to invite the third speaker. Before your presentation, Professor Makoto Sawono, I would like to introduce him. The name is Professor Makoto Sawono, MD, PhD, from Saitama Medical University, Japan. He would like to give his presentation on the title of Identifying Transmission of COVID-19 via Exhaled Breath Aerosol. And his current position he's right now as a professor of acute medicine and surgery, Saitama Medical University, Japan. He's also the director of Advanced Center for Emergency Medicine and Critical Care, Saitama Medical Center Hospital, director of Medical Safety Office, Saitama Medical Center Hospital, professor of Life and Health Science in Kubu University, Japan, and also the lecturer of Surgery, School of Medicine, the University of Tokyo, Japan. And also he has a lot of academic position and also the achievement. Right now, Professor Makoto Sawono, the time is yours.
Thank you very much. I would like to thank the chair and also the UMY staff for letting me deliver my talk here. I'm very enjoying my first visit to Indonesia, and so and the foods too. Yes, so I would like to. Could you start the slide, please? Yes, and the next slide, please. Next slide, please. Okay. Let me introduce you. Thank you very much for your introduction. But actually, I am now today for today's talk. I'm concentrating on the research, and also the research for the we call it translational research. But the research for which affects the clinical application, and also to the research for the society to survive. So, so I'm an International Scientific Committee member of International Association for Breast Research, and also I'm associate editor of the Journal of the Breast Research, which is an official journal of this International Association for Breast Research. Yes, next please. And my first part of my talk is the brief story of the global breast research community challenging the COVID-19 pandemic crisis with collaboration, transparency, and friendship. Next, please. Yes, the key players of this story is first the International Association for Breast Research. It was founded in 2005 and the only worldwide association for breast research, and organizes annual international scientific meeting called the Breast Summit. And then the second player is the Journal of Breast Research, founded in 2006, the official journal of IABR, and with a focus on analysis of XL breasts. And its impact factor is 3.5, site score is 7.6. Next, please. First, in the February 2020, actually, all of the people in the world. So it's another another same year starting of the year. However, in the World Health Organization announced an international health emergency in response to an apparent viral outbreak in Wuhan, China. It became apparent in February. However, it seems to have started a little bit earlier. So this tells you the story, the need for the transparency first. Next, please. In March 2020, WHO declared a global pandemic. Yes, this was quite a shocking news. The next, please. Next, please. Until the pandemic, the collection and analysis of XL breasts was considered with a minimal risk or no risk, zero risk, due to non-invasive sampling and the benign nature of breasts. No one thought that breast is a dangerous sample. However, after the outbreak of this pandemic by SARS-CoV-2, it became necessary to recognize breasts as potentially the most contagious specimens, as you show in the sign. So this led to complete cessation or a standstill of breast research activities and also its clinical application. Next, please. So actually, our society, the Breast Research Society, is a very small society. It consists of only 200 PIs throughout the world and their students. And in June, the Yokum Play, who is an editor-in-chief of the JBR, the Journal of Breast Research, emailed to the JBR editorial members, including myself. They said, we would like to develop a special issue for breast risk aerosols and COVID-19 related topics as a platform to for scientific collaboration in our society to reboot the breast research. Yes, he realized that the breast research was nearly such as a red booked animal who is nearing the extinction. To another, next please. Next please. Okay. My response was our breast research committees are rather small, but I also believe that our advantage as experiences and capabilities in international collaboration and communication, because as a small society, global small society, we had taken very, very intimate communication with each other. And the response from the Nando magazine, he's an expert in breast and NO, but no, we are doing, yes, he agreed that we are doing individual proposals independently, sometimes against each other. Yes, and many of these activities will fail and we will lose credibility among the clinicians. He was afraid that the people are rushing to for the COVID-19 researches. This was not only the breast research, but in all the fields, the people are rushing to publish a new data, or even unpublished data went around. Yes, and preprints. And another response from the Anil Modek, he's also UK, and the survival of the virus on surfaces and specimen needs to be addressed prior to coming up with a consensus protocol. Yes, he insisted on the consensus protocol of the safety measures. The prime aim should not be to contribute the spread of the disease. These are all the conversations done on the mailing list. And the response from the Michael Davis, USA, as always, he's my good friend. I'm eager to collaborate in many ways possible. Just let me know. I just submitted this paper to JBL. Please keep it confidential, but have a look. This means that he disclosed to me, to us, before it was published. And this was very, very courageous thing. And I thank them. Yeah, thank you. Next, please. So, October on 2020, we launched special focus issue of COVID-19 related works in the JBL with myself and Jonathan Beauchamp. He's a Jonathan Beecham, and he's English, working in Germany. And we are two guest editors for the focus issue. Next slide, please. And our team published in 2020 perspectives of our study. The first, which first reported the detection of SARS-CoV-2 RNA by RT-PCR assay in exhaled breath aerosols. This was the first one in the world, according to PubMed. And the perspective disclosed exact methods as well as the safety measures taken in the ongoing clinical study to ensure the transparency and open discussion. Because we consider, the authors consider that we should, I know it is not so conservative. It's not that things happen in the world of academics to disclose the methodology and also the measures before it is published. So this was quite an abnormal thing to do. But however, we saw that we need a transparency, as well as we need the ideas and comments from our colleagues all over the world. The next place, please. The next, yes, please. In June 2021, I have a summer online symposium 2021. The virtual breast summit was held by Christina Davis of UC Davis, and the conference chair was Professor Paul Thomas of the University of Loughborough. This only one thing that was a very good side of the pandemic was that those Zooms and those online devices developed, technology developed, and we are doing the hybrid conference now. But next slide, please. This is the agenda of the Zoom conference hosted by UC Davis, and this is very, very compact but very fruitful conference. First, the viral deactivation was discussed. And in the second one, the reflections from the clinical frontline community breast testing for COVID. This presentation included the safety, all the safety measures for the collection of the and for the COVID-19 patients to collect the breasts from those people. And the third was my presentation, and this is artificial diagnosis of COVID-19 from exerted breast condensate, a clinical study. And then please, next slide, please. Then our team first published a first full paper in the JBL based on that perspective paper. And the paper reported demonstration and absolute quantification of SARS-CoV-2 RNA in the wild type in exhaled breath and aerosols. Next one, next please. This is our first full paper published in the JBL. The paper was the first to report rigorous demonstration and absolute quantification of SARS-CoV-2 RNA, the wild type, in the exhaled breath aerosols. Yes, about this research, I will refer to it in the second part. Next slide, please. And in May 2022, our second full paper published in the JBL. The paper reported comparison of SARS-CoV-2 RNA load in exhaled breath aerosols between the wild type and the Delta variant. Because as you see, the timeline at the top shows the new deaths per 1 million people in the world. And so we were nearing the end of the it's very, very rough times of the pandemics. Next slide, please. And this was our second full paper. The paper reported comparison of SARS-CoV-2, and the topic there was the comparison between the wild type and the Delta type. And next slide, please. Then in October, we saw that the special issue or this platform for challenging the pandemics has achieved its mission. So we closed with limitations, the editorial referring to limitations and opportunities. Yeah, because the pandemic, for the breast research community, the pandemic was quite burdened, a very, very severe limitation to our research. But we could, with a collaboration among the worldwide researchers and also with the friendship and transparency, we could turn that opportunities, limitations to the opportunities. In the next slide, please. Actually, this focused issue was such a success. It's an incredible success because in this journal, in 2021, the top 5 downloaded articles, among the top 5 downloaded articles, the first, second, and fourth came from this special issue. Next slide, please. So it was actually in the June of 2022, we had a sort of celebration reunion in Pisa, Italy. It's a very suitable place for the celebrations. But however, on the way back from the Pisa, I got COVID. And this is my very esteemed colleagues. Well, we are apart from we were the colleagues, we are very, very good friends, and also this fight against the pandemics strengthened our bond. So we are now having a very, very united society. Next slide, please. Next slide, please. Now, I want to introduce you my the work that during the COVID-19. Next slide, please. Actually, in the early days of the pandemic, the major route of SARS-CoV-2 transmission was considered to be the droplets. Droplets are the droplets that has a diameter of 5 micrometers or larger. However, the WHO did not admit the more smaller droplet nuclei or aerosol is the main route of transmission until many breast researchers in the world, our virology researchers, they made a letter to WHO to force them to admit that, and so then the WHO admitted that the droplet nuclei or the aerosols, which is a smaller diameter of 5 micrometers, which is it means that these small aerosols keep flying in the air. So that means what the WHO did not want to admit is it's an air-transmitted disease. COVID-19 was an air-transmitted disease. Because WHO thought that it might be a panic if they say it's an air-transmitted. Yes, it's it reminded them of tuberculosis. And so in the other breast research world, those aerosols are collected collected as an exhaled breast condensate. This is called EBC, and this origin of EBC comes from lower respiratory tract, which is where the main infection of the SARS-CoV-2 occurs. Next slide, please. And why exhaled breast condensate? Actually, at that time, the gold standard for the diagnosis of COVID-19 was nasopharyngeal swab sampling with and the PCR. However, this nasopharyngeal sampling is a very, very unstable and also difficult procedures. Yes, when the patient sneezes or coughs, it's a risk of viral dissemination, and also it may provoke the resistance of the patients. Not patients, the subjects. Yes, I myself would resist. And next slide, please. So this is the way to collect the aerosol or EBC samples by the device using an R tube. You see the device is consists of mouthpiece and one-way valve and cooling part. And this cooling part is an 5 sleeves using the cooled sleeves, metal sleeves. And if you breathe into if you breathe 5 to 7 minutes using this device, it's very simple, and nearly 1 milliliter of exhaled breast condensate is obtained. And also, as RNA is very, very fragile, we have to keep it below minus 70 degrees. So we store the sleeves, 5 sleeves in a dry ice, and then exchange that every minute. Next slide, please. And patients were 45 patients were collected samples are collected from 45 patients during the this wild type surge, and another 41 spontaneous raising patients, and then we collected from them the EBC from the Delta variant patients. And they, of course, we've given a written consent to the participant in the study from the patients. Next slide, please. And but sampling is a very, very complicated for the safety measures. Yes, as you see, the patients are patients are in this red zone in the individual rooms. So the researcher are equipped like this. This is called PPE, and they, like that, and then enter into the individual rooms, and then they pass when they collected the samples. They pass to the passed them into the plastic bags held by the nurses in the front room or a yellow zone, and then again it is passed to another nurse holding that plastic bag into in the green zone, and then it is transferred to a biosafety level PCR laboratory. Next slide, please. And so then in the RT-PCR, this is a biosafety 3, means a very, very strict biosafety zone. And absolute quantification of the viral RNA load in EBC was, so first 100 microliters of the EBC was put into nucleic acid purifier, and this is with the recovery rate is 20%. Then the 10 microliter of the concentrate is put into RT-PCR machine. So with this formula, you can quantify the absolute. You can perform the absolute quantification of the viral RNA load in EBC. Next, please. And this is a result, raw result or raw data. And in, actually, they're nothing similar to the to the normal distribution. So we have to turn them by applying logarithm transformation to look the distribution looks like normal distribution for the analysis. Then, next slide, please. Next slide, please.
Professor Sawano,
right?
your time, two minutes
2 minutes
remain.
Okay, and this is a time course changes of the RNA detection rate. And for the wild type, it was only we can detect high detection rate for the first 2 days of the symptom onset. But however, in the Delta variant, we could the high detection rate of 70% or more was maintained for 7 days. Next slide, please. And so the time course changes of SARS-CoV RNA, this load, and it confirmed the epidemiologic data that in wild type the infectivity was only lasted for 5 to 6 days. But however, in the Delta type, it lasted more, nearly 2 times more until this was a very interesting, and also it confirmed that the infectivity of the patient is proportional to the viral load in the aerosols. So this is, and the next slide, please. And for sustainability of the well-being of our global society, the Brussels Research Committee is engaged in future pandemic preparedness, which is funded by EU Horizon Project. They give us quite a large grant, and it's called One Lab, orchestrating next generation mobile molecular laboratories for pandemic monitoring and preparedness. Last slide, please. And this is a list of One Lab project partners. As you see, this is also the international collaboration. So my study research and my is an all for this 4 years has been all on the international collaboration. So I wish to with your country, I wish to well establish the collaboration. Thank you very much.
Much. Give the applause to Professor Salano. And
Thank you.
that will be the last keynote speakers. And I hope that everybody is still enjoying inside in the Zoom meeting and also in this room. We would like to invite Professor Dr. Sri Nabawiyati Nurul Makia, or we are very familiar to call her Professor Nurma. She will give the presentation with the title Dioscorea Alata Tubers for Food Security and Health. And before she give her presentation, I would like to introduce her curriculum vitae. She's the professor from University of Muhammadiyah, Yogyakarta, with the area of expertise in a molecular biology. And she also produced some books, copyright, scientific journals. She's also very frequent as a reviewer in some scientific journals, nationally and internationally. And also she has some research as a chairman. In the 3 years final, she has and finished with the 8th title of the research, and her devotion as a chairman, and also she active. She's very active as a speaker in some seminars and conferences. So right now, the time for Professor Nurma is yours.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. And the Honorable Vice Dean, Faculty of Medicine and Health Sciences, the Committee of the International Conference of Medical and Health Sciences, and the moderator. Also, all of the attendants. I will present our result of research. Yes. My research is about the tuber of the Dioscorea alata as the food security and health.
Next slide, please.
Next slide.
Next slide. Yeah.
This is the picture of my plant, the tuber of UI or Dioscorea alata. This is the potential plant that very potential to be suitable for ingredient of developed in Indonesia, because have so many kind of active compound with have so many kind of beneficial for our health. Next slide. This is a nutritional value of Dioscorea alata. It contains so many kind protein, fiber, and mineral. Also so many kind of carbohydrate, protein, calcium, phosphor, iron, thiamine, riboflavin, niacin, and also ascorbic acid. From this active compound, it contain in flavonoid, terpenoid, steroid saponin, diosgenin, which have so many kind activity as anti-inflammatory, anti-allergic, and immunomodulatory. So in the first result of my research, I want to know the level of knowledge, behavior, and distribution in special region of Yogyakarta of this we plant or Dioscorea alata. Next slide. This is my respondent in special region of Yogyakarta. The sample is 5,078. The distribution come from the dominant come from Sleman area. The dominant people are female and the age dominantly are elderly, and then for the occupation dominantly are teacher or lecturer, and then for the income dominantly are the minimum wage of special region of Yogyakarta, and education dominantly are from college. And for the origin of respondent come from Sleman area. Next slide. This is the result of level of knowledge about this plan. The result is very good, but for the attitude and level of knowledge about the health benefit, the result is pretty good. And the next slide, the map of distribution area of this plan with the color with green color. The distribution area in special region of Yogyakarta, this plan is still limited. So the conclusion of my research, level of knowledge about we plan have very good, but for the level of knowledge about the attitude and knowledge about health benefit of we plan pretty good, and distribution of we plan in special region of Yogyakarta is still limited area. For the second of my research is about the anti-allergenic of Dioscorea alata. As we know that allergic is indicator that we always measure is immunoglobulin and IgG1 expression. In animal model of allergic digestive allergic, I use this plant with the ethanol extract, and in animal model we measure the immunoglobulin IgA and IgG1 level in the lymphocyte cell culture. This picture shows that the progress of the body weight of the animal, and then this is the result of level of IgE and IgG1. In the left tabel, left in here and here, this is IgGE and IgG. In the sensitivity phase, and in the middle, two column in the middle is in the challenge phase, and the right column, two right column are in the allergic phase. The best result is in the allergic phase for 30-day treatment of ethanolic extract Dioscorea alata. So the IgA and IgG1 lower than the positive control with drug. And the right picture is the detection of content Dioscorea alata with CCMS chromatogram, and the arrow show the active compound saponin steroid. And the next slide, I will show the phyto compound in GCMS that we found 6 active compound in here. Cleonasterol, octadecadienol, tricosanol, methyl linoleate, and caryopylene oxide, pentan 3-henicosan found in GCMS. And we compare with the virtual screening with software mall inspiration and pass online. 6 active compound have so many kind activity as anti-inflammatory, non-steroidal anti-inflammatory agent, immunosuppressant, anti-hypercholesteremic, and cholesterol antagonist. Next slide. This is the next step. We want to know the protein and ligand binding energy of the 6 active compound compare with the control. Use the 3 protein P par A, P par I, and MAPK40 with low binding energy when interacting with hexane extract Dioscorea alata compounds. It shows the interesting data. Cleonasterol as active compound have a binding energy score not significantly different from binding energy control in P par A and P par 1. And for the right figure, shown the ligand binding position and 2-dimension interaction with the receptor. I'm sorry, the pointer is not function. So from this research, so that ethanolic extract of Dioscorea alata can decrease the IgE and IgG1 level in mice model allergy, and active compound in hexane extract, cleonasterol, had a potential to become PPAR agonist and MAPK40 inhibitor due to its bioactivity anti-inflammatory. Next slide. This is the third result of our result. From the saponin steroid, we think the diosgenin, we make a isolation process to isolation of this active compound, and then this isolate used to make the in vitro research. In the next slide, I will show the isolation process of this Simplicia. From this Simplicia, I'm process this with the guided isolation POC method. From Simplicia, we make extract, ethanolic extract, and this ethanolic extract, we make the fractionation using column chromatography, and then we use the solute and hexane, chloroform, and ethyl acetate, and so methanol as solvent. The result of each fraction, we measure its steroid saponin content qualitatively with TLC or thin layer chromatography, and then the result with positive result, we continue with the preparative TLC, and then the last in the right top, we found 3 isolate steroid saponin we obtained from ethanolic extract Dioscorea alata. 3 isolate in my result, and then we process in vitro with lymphocyte cell culture. In the next slide. Now, in this slide, we measure the interleukin 4 and interleukin 5 as pro-inflammatory agent. This is so that in the allergic group, the EL4 and EL5 have the increased level, and for the extract Dioscorea alata and antihistamine have the lower, and then for diosgenin there are no different significantly. But for the TGF beta, this is the contradiction. There are increase of the TGF beta level in Dioscorea alata extract and antihistamine drug. This is, in this picture, I want to say that in allergic, we have the equilibrium level, TS1 and TS2. EL4 and EL5 are TS2. In allergic condition, TS2 will increase and TS1 will decrease. And for the cure, the TS2 will decrease and TS1 will increase. This proves that EL4 and EL5 as the TS2 decrease and TGF beta as TF1 are increased. So it will to reverse from the allergic condition into the normal condition. Next slide. From my previous slide, I'm sorry, that is the from extract. And then this is the result from the isolate. From isolate, 3 isolate that I found, and then the active isolate in this result, so just the isolate one that have the potential as anti-allergic, because from the CD4 and CD4 CD82L is the naive T cell. The naive T cell are lower and activated T cell with symbol CD4 are higher. But for the other group, it not happen, but it happened just in isolate one with very low dose. And from the isolate, like the ethanolic extract, this result show that from EL4 and EL5, it shown the decrease level from Dioscorea alata extract and saponin extract. This is the positive control with diosgenin, and for the TGF beta, the trend is increase. The next slide. So the result of my research about anti-allergic of Dioscorea alata show that ethanolic extract Dioscorea alata contains steroidal saponin, which have the potential to operate as an immunomodulatory drug by promoting proliferation of and activation of CD4 T lymphocyte. And then it modifies cytokine by elevating TGF beta level and lowering interleukin-4 and interleukin-5 level. The treatment of allergic illness has logically focused on drugs that block important Th2 cytokine like interleukin-4 and interleukin-5, since Th2 responses are what trigger allergic reaction. It believes that steroidal saponin chemical that make up the ethanolic extract Dioscorea alata tuber what give its immunomodulatory and anti-allergic property. Next slide. My next research are about the anti-diabetic agent of Dioscorea alata. This research, we use the normal or healthy teenager to analyze the activity of Dioscorea alata, and then we explore the mechanism involved through in vivo, in vitro, and in silico experiment. Next slide. This research, we use the in vivo experiment with respondent. We use the student from UMY. We give the Dioscorea alata administration. And then the in vivo, in vitro, and we use the preparation of Dioscorea alata and steroidal saponin with lymphocyte cell culture and with immunostaining and FACS analysis. And for the in silico, we use analysis of the compound contained in Dioscorea alata with Kishar analysis, protein target analysis, and protein-protein interaction atau or PPI. Next slide. This is the respondent for the normal respondent. This is the nature with weight normal, height normal, body mass index normal, and blood pressure normal. And then the next slide is the result of level of glucose of blood. Next slide. Our respondent fasting in 10 hours, and then we take a blood glucose level. The control group, we after fasting we give the glucose with dose 25 milligram per kilogram body weight, and the treatment group we give the Dioscorea alata. After we give the treatment, 30 minutes after treatment, we measure the blood glucose level. It shows that for the treatment group with Dioscorea alata, the blood glucose level is still stable, and for the control group with glucose increase level, and 30 minutes after treatment, the glucose blood level in decrease, and then 2 hours or 120 minutes after treatment, control and treatment group have the lower decrease blood glucose level. So the result in the next slide.
Professor Nurma, your time's 2 minutes remains.
Okay. This is the result of protein in the Dioscorea alata. We found that TNF alpha, CD4, and interferon gamma have decreased. And the next slide. This is in silico result. Anti-diabetic compound from Dioscorea alata is leucocyanidin, naringenin, peonidin, allantoin, and the main role to treat hyperglycemia, mitochondria dysfunction, inflammation, and insulin resistant. Next slide. This is the betweenness centrality for the protein involved in diabetes mellitus pathway. Next slide. This is BPI result. Next slide. Too many slides. But I can use this. So this is the conclusion that the Dioscorea alata possibly had anti-hyperglycemic effect due to its activity to stabilize blood glucose level after eating in healthy people. Next slide. This is for anti-diabetic, and for the subchronic toxicity, we make a research with in silico and in vivo with the mice. The result show that this subchronic toxicity for 90 days subsequently, this Dioscorea alata are in this study are not toxic. And for the in silico study, in the next slide, some of the compound contained in this plant have toxic activity, but in the single compound, not in the merger in this plant. In the next slide, next, so many time. Nah, this is for the 90-day treatment with rat. The conclusion show that Ratus notolegicus had no toxic effect based on score of degree of liver cell damage, bilirubin level, SGPT, and SGOT. Next slide. This is research with ovarectomized rat, and we measure the bone calcium level. But in this research, no effect in the increase of bone calcium level, maybe because the dose of the treatment not higher and not longer treatment. This is the last research. We make uwi cookies for cookies hedonic people. And next slide. I'm scared because Bu Upi always see me. The sensory characteristics. So
I'm a moderator, so
yeah. Yam composite cookies.
timekeeper will be very important.
We make two kind sweetener with stevia and with glucose. The stevia sweetener are more healthy but less desirable. Yes. The last closing statement. Prospect of yam as food diversification ingredient can be done by developing yam processed product into semi-finished products such as flour. So processing yam flour into modern food such as cake, flakes, muffin, vermicelli, or noodle, or as a thickener for pudding, sauce, and flan. And the last is good nutritional benefit add to excess value of yam tuber. So this potential need to be developed. Research to explore the health benefit of Dioscorea alata is still very wide open. I'm sorry if my time.
Thank you very much, Professor
Assalamualaikum
Nurma.
warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Very big applause for all 4 speakers. And right now is the Q&A session. So I would like to invite all the speakers to come and sit down on the stage. Please, Professor Sawana, Professor Nick, and also Professor Nurma. And of course, Dr. Mulyoto is still on the screen. I hope that that would be some questions coming from, okay. Somebody is already prepared with the question. And also, I would like to invite all the audiences on the screen. On the Zoom line, because that would be very good interaction between the audience here in the room and also in Zoom room with all the speakers. So please, maybe the committee, one of the committee can deliver the microphone to the, Can you deliver the microphone to the audience? One audience will deliver the question. Okay. Oh yeah, Dr. Triwulandari first.
Yeah. Thank you for the opportunity. I have 2 questions. The first question is for Professor Nick. Yeah. My question is, what do you think about the benefit of milk consumption, milk consumption in the menopause women? Is it effectively for cure or maybe for prevent the process? Yeah. This is the first question. The second question is addressed to Professor Sawono. Yeah. Is it possible to diagnose with your method in COVID, but to diagnose in tuberculosis infection? Is it possible? Yeah. Your method in your infection, COVID infection.
Is there any question? Oh yeah. Please, you can also your name and your institution.
Okay, so can sorry. Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Okay, good morning. Yeah, sorry. Keep spirit. Good morning. I just say good morning. I can see so sleep, so tired. All people here. Yeah, keep spirit, brother or sister. Okay, doctor. Thank you very much for chance to me to give time for. So just disclaimer: I'm not from the health department. I'm from the economic department. But I enjoy. This is the interest for me. Because on senior high school, I'm from IPA, Indonesia. Is it IPA? Yeah. Okay, from IPA. So we have for the question, inshallah equal all the speaker. Inshallah, I make sure all the speaker must have the question, inshallah. Okay. The first for address to Prof. Haslina from the Malaysia, from the Saints Malaysia. Okay, sorry. Angga Brizalmon, sorry. I'm from the Master of Economics, the master in UMI. Okay. So my question is regarding about andropause or monopause in for male. This is not general in Indonesia. This is the first time for me to I read the some of article. Oh, for men have monopause. This is the new knowledge for me because I'm from economics. This is so long knowledge. So maybe you can. Sorry. Different. Maybe I mean like, are there any different impact, yeah, for woman or for male, or for female or male is the same impact? Is the first question for. So the second is for to Prof. Makoto, okay, from university. Okay, so I'm very interested about your reason regarding to talk about COVID-19 because I think 1 year ago I researched about the COVID-19, but regarding integration economic and health. Jadi this is same I like image with economics and health, economic health, right? This is how to be connected about the economic and health because this is the foundation how to make economic growth in Indonesia in general. So my question is, in your country, Prof, do you have like a threshold to detect the mitigation this COVID very dangerous or not? Like a threshold or mitigation. Do you have like threshold? How many people like COVID active or not? You have that threshold. This is the problem or not problem? Or is it normally just something like that? Okay, this is the from Prof. Makoto. So the third is from in Australia. Dr. Mulyoto. Yeah, because Dr. Mulyoto. Okay, so I think we have question for Dr. Mulyoto. Dr. Mulyoto stand here or Zoom?
He's still online.
Okay, we have question regarding about what is the high impact of infertility in the world. What is the leading or the high impact to the influence for infertility for us? Because I'm get married, prepare about my health for maybe in your generation, right? Okay, this is the question. How is the leading or main indicator to impact? So the lastly for Prof. Sri or for Ibunda, Prof. Sri, we have question about the process. In Indonesia, called is the uwi ungu. Yes, Indonesian call is uwi ungu. So you can deliver, you can expand, but I think still confused because I'm not from the health medical. So maybe you can give me advice. What is the process to make other product based on the ungi? Like something maybe crispy crispy maybe or something. Yeah, I am still confused. What makes idea from economic to make something like? Okay, thank you. Let's do it. I'm sorry for very long to talk something. Okay.
Problem. Thank you very much for excellent questions. Yeah, I think right now I would like to invite all the speakers to answer the questions from the audience. Whether if we still enough time, then we can continue to the next step. Thank you. Maybe the first from Professor Nick. Yeah.
And thank you, Bu Upi. Okay. I think it's a very good question from Prof about the milk consumption. Okay, for milk consumption among the menopausal women, it's not enough actually. It's not enough. If you are less than 35 years old, at least okay. When you are already menopause with the evidence of hypoestrogenic state, it's not enough. There's still a risk to get osteopenia, osteoporosis. That is, it's good if you start the MHT hormone, or maybe when you got the osteoporosis ready, maybe you need a proper treatment for bone, like a drug for bone, for the bone formation, or also at the same time to reduce the resorption, a medication like the phosphonate or other medication by the name of sontiranolate. Sontiranolate is got two action. That means to increase the bone formation. At the same time, the action is to reduce the bone resorption. That means it's not enough with the mud only. But also it's good if you can take a istiqomah, a long-term practice, maybe still from the young age, you would like to start to use honey, maybe it's okay also. That we also did a long-term study, use the honey. But in Malaysia, we got the tualang honey, and also we got the honey from a stingless bee, the kelulut actually. And it's also good for the bone, but need to be used for long term because that one is a natural product.
That means that you have to use start it from the younger.
Yes. Okay. And then for the question that was asked about the andropause, menopause, very andropause. It's a very, very good question. Okay. You are still very young. You are still very young. Yeah. Actually, even though there is a menopause. I mean no menopause. But there is a condition that layman term we call andropause. But even though in a medical term actually there is no andropause actually. It should be we call a PADAM, PADAM. I mean it's a partial androgen deficient in aging men. Or TDS, testicular deficiency syndrome. That means because the difference between the men and women, even though the symptom can be the same actually, they also can experience hot flushes, poor memory, insomnia. The symptom can be the same. However, for the men, they do not have for the women, they start the follicle, the ovarian follicle, start from maybe got number until they reach a zero. Nothing, no more left already. That's why they got a menopause. But for a man, they still continuously producing, even though the number is low, but still have. That's why we put PADAM. That means partial androgen deficient, or testosterone deficient syndrome. And also, last night we gave a book as a souvenir to Dr. Iman last night, andropause, about the andropause in Bahasa. Actually, in Bahasa, we managed to publish under Dewan Bahasa and Pustaka. They already maybe published, I think, about more than 10 years ago. Andropause reality atau apa dah tak ingat, dah lupa dah tajuk. Something, is it real or not for the man? But we published that book. Actually, our intention just to disseminate knowledge to educate the public actually about the andropause. Because sometimes the layman they easily use the terminology like andropause, even though in medicine it's not really proper actually. Did I answer your question? Okay, thank you.
So after this conference, you can copy the book from Dr. Iman. Yeah. Oh, you have to buy from her. Okay, no, just kidding. Okay, maybe Professor.
For a very interesting question. I think, and that was that tuberculosis is another our target, because in Japan now the tuberculosis is very rare in Japan. However, in the worldwide, the tuberculosis is a very concerned disease. It's actually it's disease of concern by WHO still, and so I am now making a study. This is the study between U.S., Japan, Algeria, and UK, and actually UK and US has a need for the tuberculosis tests because of the number of the immigrants. As you know, Japan has a very small number of immigrants. So, but so far, theoretically, this might device is capable of diagnosing or screening tuberculosis patients. However, one difficult thing is that tuberculosis does not transmitted through aerosols. They're air, the particles. So that is maybe an obstacle to that. I'm still trying to diagnose that, but still, well, it's unknown. Sorry. Yes. And another question about the diagnosis, the drugs. Yes, we have done the study on the RNA loads in aerosols. And comparative study between the drug administered patients and not, and so to the disappointment, the drugs did not suppress the RNA load. The drugs only suppress the symptoms, and so that means that it is said in Omicrons that if the drugs suppress Omicrons, the Omicrons is they have the symptoms very mild. So that means that the mild symptoms has even the same infectivity or more infectivity. They're very in good condition and disseminating the virus. So that means that the virus may be, the drugs may be maybe help the dissemination of the virus. And also, as you are in the economy, in the field of economy, I tell you, in Japan, the drugs had been free, totally free, until this April. But from May, it became the 30% of the had to pay yourself. It is, and only 70% is covered by insurance, and that dramatically decreased the prescription of the drugs.
Yeah, thank you very much for your question. My plan, my UI are the annually plan. So this is not always ready in all the time. So this is the one of the obstacle. And then but for this plan, if we harvest, it can, for one tuber, it can reach 10 until 30, 25 kilogram in one tuber. So from my research with to explore the level of knowledge, as you see in my research, the dominantly people with the elderly age which know this plan. So I want in my research, I want to make this plan more famous and to make it more interesting, more people will interest to eat, to consume this tuber. I think my research, I try to make it as a cookies, and for the community services, I have the competition with the make innovation of this tuber. I make this flour to Ibu-Ibu Aisyah, and then they make innovation with this plant, with this flour. Then they make bakso, they make the crispy, they make the muffin. pudding, and etc. So I think this plan with the active content with the beneficial for health, it potential to be more exploration and more research about this tuber. I think enough for my answer. Thank you very much.
Thank you very much, Professor Nurma. We still left with one question and it's preferred to Dr. Mulyoto. Dr. Mulyoto? Yeah.
Yes, thanks for the question. It's very interesting question and make everyone aware about what the situation. I think if someone get married and then the best is just check their fertility, such as the easiest one for the husband, just how the sperm quality. So it's very simple. Just produce the sperm by masturbation and then bring it to, I mean, of course you need a referral from the doctor and then bring it to any clinical lab, then they will give you the result within 3 hours. If no one there, it's no other patient, then when we do it within 2 hours, they can get the results back. Or depend what kind of assessment they will do. If you look at the concentration, motility, abnormality, it's very quick. So the next question is how to prevent that one. I mean, most people, if they're living in a healthy condition, such as they're not awake overnight. I mean, most people, like, in Indonesia, we call it begadang. It's not good for men's health. Or eating fatty food, like in my presentation, like I know most Javanese like to eat like jeroan, kikil, the offal, the fat of the meat. That's not good, but somehow there's a delicacy. So like I myself still like eating offal, jeroan, babat, and etc. But I know if you consume it in a moderate amount and then you also having a healthy life, like you do exercise, you also eat a healthy food such as vegetable, fruit, and everything, this will help you to prevent any issue with your fertility. Not just for men, but also for women. So if you want to check, if you're newly married, then the best is to see what's happened. Is just get your sperm sample, take your sperm sample to any lab, then they will tell you what's happened. If the result is good, it doesn't mean the problem lies on your wife. We need to look at further. I mean, the sperm quality good, but if they have like antibodies or anything, that's when we go to next step of assessment or examination. So if you in that case, hope not, you can see your doctor as a referral to go to any lab, check the sperm, and then it's not expensive, this one. And yeah, I hope everything's come up good and positive. And of course, you soon you're gonna have your own children. Thank you.
Yeah, thank you very much. All the questions are resolved by all the speakers. Is there any questions from the audience? Oh, yeah, still many questions. So, this conference is really interesting for every people.
Thank you for the opportunity. My name is Misna Sabila from Universitas Indonesia. Okay. I have 2 questions for Professor Nick. Nowadays, we have found many young girls has having menstruation in 8, 9, or 11 years old when they are still in elementary school, yeah. And there is a belief that women's age are limited and it will decrease until 0. Does early menstruation cause a woman to have a earlier menopause, and how can early menopause prevented? And the second question is regarding menopause hormone therapy. The speaker mentioned that it should be given to women before 60 years old. Correct me if I am wrong. But in Indonesia, I think it's still limited or rarely found in community. The question is, are there other specific criteria for women should have hormone therapy? So thank you.
Yeah. Is there any question from the others audience? Oh, okay. Yeah. You want to ask to Professor Sawano?
Okay, I'm Gali, and I'm also a liaison officer for Professor Makoto Sawano. And I curious and feel interested for your research for the EBC, and I want to ask like how the exhale breath can be accurate data, because I read some research or article from the Journal of the Health of Breath, and there are said that the RNA of the COVID-19 or SARS is in a basis of the lung. So how the exhale breath, our exhale breath, can be the specific data to describe this delta types of the COVID-19 like this.
Yeah. Is there any question? So I will give the chance, the opportunity to Professor Nick first.
Okay, thank you so much, Bu Upi. A very good question, Dr. Camila. Okay, I answer the second one first about MHT. Why maybe it's not really quite popular in Indonesia. No need to worry about that. Actually, in Malaysia also. That's why we managed to come up with the second guideline last year and 2 years ago in 2022, and we plan to do a roadshow actually to all the state in Malaysia actually, because at the moment actually since after 2002, that means not just the women menopause, but all the doctors also pause. They stop the treatment. They stop to treat the patient, the women with menopause actually. After the WHI report, I'm very sure that you are very well versed about the WHI, the Women's Health Initiative study that was conducted in 1998 till 2002. And then the media tried to manipulate the data, and they mentioned that everywhere in the media, in the television, that they said that HRT, that time is HRT equal to breast cancer at that time. So all the ONG specialists stopped the medication to the women actually. And then 5 or 10 years later, they reanalyzed the data actually. It was manipulated actually. It was misquoted actually. That's why now we come back actually that this is the best treatment. MHT is the best treatment. You need to start early. That's why I put here actually MST is the best treatment, because now actually it's our responsibility as a doctor or the practitioner that we need to educate not just the public but our doctors also. That's why we come up with a guideline. We want to train our doctors to use the guideline, and then to train the general practitioner also, and for the undergraduate also. So that we hope we can come back to use the MHT to our women. That's a problem. It's a normal problem. Okay. And for the first question, how to prevent early menopause? Actually, it's not easy. It's quite difficult also. But I think try to prevent smoking, not to smoke actually. Try to avoid to get like the diseases that if you can prevent, like autoimmune disease, or maybe the infection like the mumps, but like the chromosomal abnormality, I think you cannot do the prevention, like the Turner syndrome. You cannot do the prevention. That means for sure that even though they never experience menarche, they already menopause. But for us as a doctor, we need to treat them. Start with the hormone treatment, so that we would like to prevent them, for them to get the risk for the cardiovascular disease, because they are at higher risk to get all sort of problem. Not just CVD, but osteoporosis, all sort of problem. And especially the quality of life and the psychological problem also. Okay, and also can I add a little bit question about the infertility, because the topic is very, very near to my heart. That I agree with everything that was mentioned by Dr. Mulyoto just now, but I think that for the young men, okay, that everything you need to check your diet, the fast food, especially the fast food, McDonald's, KFC. Try to avoid that actually, the fast food, because for the fast food, the factory will do something. They inject the hormone, the growth hormone, to inject to the chicken so that they can grow faster. But in the hormone, that hormone is look like very resistant and it's live. That they got the estrogen actually. So sometimes if the man continuously use or take the chicken, the fast food, sometimes they prone to get gynecomastia, enlargement of the breast, and then they got more feminization, little bit like women, or because of hyperestrogen, the female hormone. And then other thing that you can avoid, actually try not to use the tight underwear, not to use the hot under the hot or sauna, warm bath, smoking. Stop smoking, avoid smoking. And also, as I also produced a book actually together with my husband. For the infertility, we got 5 books in Bahasa that was published about more than 10 years ago. So the first book is about Hala 7 Cabaran dan 1000 Pengharapan. That means a general thing about infertility. The second one is 100 persoalan berkenaan infertility, but in the form of Q&A. Is a common question that was asked by the patient. We try to compile. And other book actually, one more book is about rawatan dengan teknik bantuan reproduktif. Maksudnya is a book in detail about IVF, but in bahasa. For that means the wording is everything for the layman actually, for the public, because we want to educate the public. Other than that, is about Sinar Harapan di Sebalik Impian, is more of a psychology book actually, for the infertility, for the infertile couple, when they need, what are the things they need to do, how going to handle the problem with infertility, because they are prone to have depression actually, psychological impact, very bad impact. And also one more book is about a specific thing about problem, polycystic ovarian syndrome. Syndrome ovary polycystic, dan infertility lah, something like that. That's why, and also I managed to produce that I pass to Bu Upi last night, a novel, one novel specifically discussing about a story about a real patient. I do adaptation, Cinta in Vitro, something about in vitro fertilization, the IVF. But the real thing, because I would like to educate the public so that they need to know how's the feeling of this couple actually, the unlucky couple actually. I think that's all. Thank you.
Right now, for Professor Sawan.
Thank you very much for it is a very good question. And actually, this is many researchers has made a research in a study into the origin of where the SARS-CoV-2 grows, or if you are infected. And the infected site, we now know that the infected site is a lower respiratory tract. And what we collecting is actually it's an aerosol hitting the your nose and also your tonsils, and your upper your deeply into your nose, and then they hit there. But you know, from the PCRs, even the you have no infectivity. It is very often, and the PCR it's become the positive PCR. So that means that they have no activity already. So those nasopharyngeal swabs are collecting the dead body of the or fragmented RNAs. So that is not at a quantitative at all, but for the aerosols, they are all living, yes, and not fragmented. So as I have shown you, the viral load and RNA load, it will go down to zero after some days. After very quickly, it goes down to zero, negative, far earlier than the nasopharyngeal swabs. So in that means quite the EBC or extracellular condensate or aerosols have very high quality specimens in terms of recovering the RNA from that.
Okay, so I think constraints of the time, yeah, and of course we have to move into the closing of International Conference of the Medical Health Science in this year, and before I give to the time to the Master of Ceremony, we would like to thanks to the 4 of the speakers, and please give applause to them. And of course, if some of you are still having the question to them, you can ask also outside of the conference and maybe send the email to them. And on behalf of the committee for the 8th International Conference of the Medical Health Sciences 2024, I am Upi Supriyatingsi, would like to close the plenary session in this afternoon, and thank you very much for all the audiences which still with us in the room and also in the Zoom meeting, and we would like to give the time to the Master of Ceremony. Thank you very much for the attention.
We will have photo sessions after this. Wonderful ideas and innovations have been shared. Yet, new challenges may still be approached. That's why we, as medical personnel, must adapt and improvise and be the best doctor for our patients.
Next, the Faculty of Medicine and Health Sciences, Universitas Muhammadiyah, Yogyakarta, will give souvenirs to our outstanding speakers that are present with us, that will be given by Dr. Dirwan Suryo Solarto, SPF MSc, to Dr. Dirwan Suryo Solarto, SPF MSc, Profesor Dr. Nick Hazlina Nick Hussein, Profesor Makoto Sawano MD PhD, Profesor Dr. Sri Nabiwiyati Nurul Makiyah, please come to the front.
Okay, so next we will have photo sessions with all the audience. So maybe the photographer can be here. And maybe all the speakers can come to the center. Can sit to the center, and also all the audience can move to the front. Yeah. Can just sit, and then we'll take a photo from here. Okay, I'll count 1, 2, 3. 1, 2, 3. 1, 2, 3. A freestyle? Anything?
Anjir parah banget.
Yeah, we are classmates. Yeah.
This is your classroom.
Yeah, this is our classroom.
This is the classroom or your bed. Sleeping bed.
Ini masih ada closing.
Oh, closing. Oh, closing.
We are grateful for all speakers, participants, and moderator that has filled our journey for new innovations. And may it'll take us to another level of medicine.
For this session all has ended, but don't worry, parallel session is yet to come.
Thank you for all audiences that has connect from the comfort of your home, wherever you will be, and also here with us, as you are all the real innovators. Once again, I'm Nara.
And I'm Abi, wishing you all well and in good health.
Wassalamualaikum warahmatullahi wabarakatuh. So for those who asked in the beginning, earlier, we have some prizes for you. So anyone who asked questions, okay, maybe for the yeah. Gali also asked.
Ayo Gali. Satu lagi, iya.
I'll never forget you, Gali.